Everybody, we appreciate you joining us. My name is David Porter. I'm the Director of Membership here for the Washington chapter of HIMSS. This is our very first webinar, so welcome. This is definitely, I'm sure there'll be some kinks that we'll have to kind of work through, so we appreciate the flexibility as we're kind of working through those. So I'm just going to be moderating, obviously, and proctoring the questions and whatnot. If you have specific questions that you'd like to ask that maybe haven't come up, please fire those off to Dylan. If you use the chat function, which should be at the bottom of your screen, you can click chat and then select specifically who you'd like to send that to. Dylan, I think are you under the Washington HIMSS?
Yeah, so hi, I'm Dylan, and then you can just put me under Washington HIMSS, and those questions will come directly to me, and we'll look to make sure that we answer as many questions as we can in the time that we have.
Yeah, and this is definitely meant to be collaborative. I mean, that's for sure the reason that we are hosting this is obviously we want to be able to share ideas between the different organizations here in the Washington area. So as of for right now, at least for today, if you want to answer, just go ahead and obviously unmute yourself and go ahead and answer. There's probably going to be some talk over one another, so just obviously be polite and give way if you will to be able to do that. So again, we appreciate doing this. The topic today is telehealth, and so really kind of the first question that we'd like to kind of go around table, and if we could some folks from each of the different organizations up here, that's the ideal. So the first question is kind of what were you doing prior to COVID, or the whole COVID situation? Obviously with telehealth, it's been thrust to the very forefront of what we're doing as provider organizations across the country. So what were you doing prior? What are you doing now, if it differs potentially from since the COVID situation has come down upon us? And then will you continue to do the same things moving forward? And if not, or if you think it'll potentially evolve, we'd love to hear that. So whoever wants to potentially start, Emily Jacobson, if you want to potentially talk about what Prov is doing, that'd be a good place to start, or whoever.
I should address it.
Hi there, can you all hear me?
Yes.
Awesome, thank you. So at Providence, we've had a fairly large telehealth footprint for quite some time. We've used it a lot in our immediate cares. A lot of our clinics had been using it already for video visits. And with COVID, it kind of thrust us into a little bit of a new terrain. So we did increase, obviously, some of our video visits that we were already doing, but we were able to work with an organization and create a way for patients to go on and interact with a bot that would direct them to the correct types of visits that they might need. So maybe they needed a video visit, or they needed to come in and there was some interaction that could happen to get them there. One of the other things that we have done quite a bit with the COVID situation is we started doing this thing for monitoring patients at home. So once patients were in the ED and we suspected that they had COVID, we were able to send them home with a pulse oximeter and a thermometer, and set them up so that they were able to report their vitals to us electronically. And then we would have our telehealth.
You might want to state next to
Oh, I think we're getting some feedback from somebody. We'd have our telehealth ICU nurses monitor them. So we had patients that were being referred to the telehealth program, and still are, that were admitted and met criteria where they could be discharged as long as they were continuously monitored. And then they would have real-time interactions with those nurses if they needed to come back in to the ED to get seen. So we've been doing a couple of things there. We've also done some exploring of hospital at home, haven't kicked that into full action yet, but just trying to be more creative to keep people out of the hospital for multiple reasons, so that our system doesn't get overwhelmed, but also so that we aren't exposing them or others to the virus unnecessarily.
Did you find that you had all of the platforms and software already in place, or was there anything new that you potentially had to implement in order to be able to handle the volume that brought with everything from the COVID situation?
Yeah, so we are mostly an Epic shop as far as our EMRs are considered. We do have Meditech in our California areas and Texas, but as far as Epic was concerned, we thought, oh yeah, we can do home monitoring via MyChart, and did a bunch of build to make that work. We found out pretty quickly that that wasn't scalable. It also didn't have the functionality that we needed to make that work as efficiently. We didn't have the ability to do notifications if a patient was an hour late for reporting their vitals, or some of the things that we really wanted to make sure were happening, and some of that trending and dashboarding real time. So we quickly pivoted and moved to an integrated workflow with Epic and Twistle. And so we were able to do more of that dashboarding and monitoring of vitals and getting alerts, and having patients not have to log into MyChart on their phone or their computer to report their vitals, and just respond to text messages, which was way more efficient and easier, and able to put delegates in place in case the patient wasn't able to do their own vital reporting. So that was something that we were able to accomplish pretty quickly and scale across our EMR platform. So we were able to scale that with our Meditech areas as well. And then it also allowed us to move away from just doing the ED and inpatient discharges and move into the ambulatory space.
Great. Do you anticipate potentially needing to evolve or iterate anything moving forward? Do you think, I guess, from a procedure strategy perspective, that anything has changed now?
I would say that in the short term, our goal is really to focus on COVID and how do we do that. I think initially we had some struggles scaling, just because we took these nurses who were really used to working in an inpatient setting, doing telehealth monitoring, tele-ICU monitoring for inpatients, and now have them working in an outpatient setting. So I could see us doing some additional monitoring of chronic diseases moving forward, or having ourselves set up for a future pandemic. Hopefully that does not happen. But I think in the short term, I don't know how short-term COVID is going to be. I think we're going to continue to leverage at-home monitoring as much as possible, so that we can isolate patients and keep them from exposing our healthcare workers as well as other patients. But I think long-term, we will start looking at how this can be used for other disease processes.
That makes sense. Did you potentially have to change, this is obviously, it goes right along with, but did you have to potentially change any of your strategy around reporting or just even tracking from maybe an epidemiology perspective?
So one thing that's interesting that we're doing simultaneously, or in the middle of, is we were in just, as COVID broke out, we also went live with Epic's infection control module, Bugsy. So we're continuing to roll that out right now as we're in the middle of this pandemic, and some of the reporting tools that we're able to leverage at our Bugsy live sites versus our non-Bugsy live sites is pretty interesting, and it's really helped shape how we're doing a lot of our reporting. I mean, I think most people know Providence is fairly large, so we're across 3 separate instances of Epic, so trying to collate that data is sometimes difficult. So we do a lot of Power BI reports. We're looking at those. We're also trying to look at various databases that we can pull from the public health organizations, and have started to do some work and are very close to looking at how we can go live with monitoring patients and their location close to people that have tested positive. So right now we're looking at 10 meters. Does that make sense? And just trying to figure out all of the options for trying to be a little bit more proactive when someone shows up, and have they been exposed, and should we be taking extra caution?
That makes sense. Thank you.
Mm-hmm.
Is there anybody on from Multicare that could potentially speak to what you guys are doing down there in Tacoma?
Yeah, thanks. This is Beckett Mankey, the CMIO. I think I would report out almost exactly what Emily reported out. similar across almost all those those areas. We had a pretty established telehealth presence, especially in our urgent care, so we were able to rapidly scale our Hypnosis platform. We did have to take off the video visits very early on, just we could not staff to keep up the volume of our video visits because we saw about a 40 times growth in that space. Similar to Providence, we had a bot that would direct folks either into self-care, virtual care, or occasionally in-person care, but with the directions about calling ahead of time. In our established patients, primary care and specialty, we use both MyChart visits and also we use a standalone video app called LifeSize. We were able to scale up LifeSize a lot faster than our MyChart video for reasons that most Epic shops are probably familiar with. But again, we've seen about a 40 times growth. I think we're slightly over 50% of our visits are now virtual for the month of April. We started to get into the inpatient realm like folks did. Fortunately, the pandemic wasn't so bad. So we developed some inpatient workflows, basically iPad on a stick, to allow our consultants and hospitalists to round remotely if necessary, if they were quarantined. And then we also did a little bit of work for our COVID positive patients using, I'm air quoting telehealth here, but allowing them to basically FaceTime with their family. So we used the Doxy platform for that, for ease of use. I suspect we've had the similar challenges that Emily talked about, but this has really been a great opportunity to rapidly scale our use of telehealth. I'm curious what others are finding. So of our virtual visits, we're a little less than 50% are telephone, the rest are audio and visual. And I'm curious, what other folks are finding as well.
That makes sense. Do you anticipate in the future that the scale, I think you said 40 to 50% at this point, do you anticipate that continuing to rise, or do you maybe
well, I think,
I'm just curious.
Yeah, I think it'll probably drop as a percentage. Our ambulatory visits are down around 25%. I think that 25% will be made up with in-person. So the absolute value probably won't change a whole lot. Our providers, I'm actually having to pull some providers back into the office. We've had providers call and say, oh yeah, change my entire June schedule to virtual. And we're like, oh, hold on, you can't stay at home forever, folks.
It'd be great if we could though, right?
Some days, a beautiful day like today, absolutely.
Makes sense, absolutely. Any other organizations want to potentially fire in here, whether it be Seattle Children's, UW? I'd love to hear what I think we all would, what others are doing as well.
Hi, this is Elena Moreno from UW Medicine. I'm actually on the training team with the D1 project that's trying to make Epic go live now in January instead of October because of COVID. So I can't speak to everything that's been going on behind the scenes, but I get the million of emails on the other side. And because we have Epic on the ambulatory side, but not the inpatient side, they've been completely swirling and absolutely running marathons to, they have ramped up their telehealth big time. They had a physician, one of our physician champions, I forget his real title, but in IT that helped make a ton of just Zoom recorded videos to kind of train people really fast. And I'm on the training team, but on D1, and we haven't learned or done anything with that yet. They just got the physicians ready to go. But we're talking on our team about how to do that sustainably long term when that just becomes the new normal or a new option for the new normal. Because we can't just let it all fall on one physician, but hopefully we'll partner more with them and continue to look at how to train, onboarding physicians, because we're academic or teaching hospital. So we get tons of folks coming through getting trained all the time on the EHRs. And so it's a future topic for us, but right now on the ground, they're just doing whatever they can to make sure the clinics are being able to have telehealth visits.
Yeah, that makes sense. Did you have to, did you utilize an e-learning platform to potentially train the end users, the physician, clinicians, et cetera? Just curious.
Yeah, the physician that made the videos a while back had started to really explore capabilities in Zoom long before we all knew what it was or started using it regularly, and figured out how to record them and post them as MP4s on a OneNote and grab them off SharePoint, things like that. And so we've learned from him, as well as explored some of our own options to do that, even with our legacy system, Cerner, that's still happening on the inpatient side. We are using Zoom recordings a lot to just show demos and kind of bare bones training. It's a show and tell. It's unfortunately not very interactive, but we're trying to figure out the best way to do it, including how to train 22,000 users for our go live in January that need to now learn Epic. So there's very fast learning curves happening all over the place.
Yeah, absolutely. Absolutely. What about potentially Peace Health? I don't know, Will, if you're on the line, or anyone from Virginia Mason and or Seattle Children's? No worries. I think one question that I think a lot of folks have, and this is kind of to anybody who wants to answer it, but one of I think the questions that came in most significantly or most common was potentially security and or operational concerns, whether it be with Zoom, WebEx, obviously Teams, any of the video platforms. I guess obviously Zoom was in the newspaper a little bit from some folks just dropping in and whatnot, but I'm curious if anybody's experienced that, or what protocols potentially that you put in place to make sure that didn't happen, or to ensure that didn't happen.
My mother's starting out saying she doesn't think she wants the hotel. I asked her why. I'm waiting to see what.
I think that was some random feedback.
Yeah, so it's Beck and Mankey from Multicare. I'll tell you, we begged people to some degree to ensure that they were using one of our approved platforms, which for us largely was LifeSize. LifeSize has a few clunky pieces to it. What we found was, well, one, we took our provider optimization team. So we have 2 different provider optimization teams that do our EHR optimization in the clinics. We took them, repurposed them to rapidly scale our telehealth platform, which was helpful. We pretty much said, if you want to use our provider optimization folks, you need to use our platform. And if you decide to go rogue, then we can't support you. So that tended to work out pretty well. As I'm sure everybody knows, there's a host of vendors out there right now that are offering all kinds of free stuff. And some of them have some pretty nice workflows, and I'll use Doxy as an example. But we said, listen, if you go the Doxy route, we can't provide you support either from the help desk or from a security standpoint. Of course, then when they waived the HIPAA requirements, or said, you know, they're not going to punish anybody for those, it got a little bit crazy. But having our optimization teams be able to go out and physically sit with them usually took care of the problem. I think everybody's using approved platforms.
Yeah, that makes sense. Thank you for sharing that. Did anyone else have anything potentially different that your organization did, just out of curiosity? Got it. Okay. From a strategy perspective, whether that be mobile or digital, obviously that goes right in line with telehealth. I'm curious, did anyone have to potentially adjust their strategy and or do that on the fly? And if so, what did you do? Lots of folks.
So Yeah, so this is Dylan. I can share what, when we talk about strategy as it relates to telehealth, I can share with you all what one of my clients is doing in the Midwest. Part of obviously they're looking at, obviously they're looking at hurting and declining revenues, obviously from not being able to have elective cases in their organization. And so as they look to get back to normal, part of their strategy is also understanding some of the guidelines and some of the breathing room that's been allowed on telehealth and telehealth reimbursement. How can they actually leverage these most recent investments to then help drive additional and near-term revenues into their organizations? So one of the organizations I was working with today is actually looking at leveraging their telehealth capabilities to be able to, sorry, I have a new call, be able to actually offer telehealth services directly to employers. So this type of direct-to-employer contract is either a direct contract that health systems would have with large employers. So to give you an example, in our area, this would be your companies like Amazon or Microsoft or Boeing, where what they're doing is then taking the same infrastructure that they've just invested in, and then actually setting up a direct contract with these employers to then have either a flat rate fee or a percentage of premium to then offer telehealth services to them. And again, what they're trying to do is these organizations are looking to get back to normal and to bring their staff back into the factories, back on sites. They're looking at how they actually leverage those protocols and screening those members or screening those employees as they come back in. So they're actually trying to use telehealth strategy to be able to offer real-time screening in that way. So a little bit of different employment strategy, but it's kind of like how are we getting back to normal, and what can we leverage the tools and the things that everybody's adopting right now. So I thought I'd share that.
Yeah, I think that's one thing that's interesting that you kind of touched on, and that was a question that we had gotten as well. But from a research perspective, obviously, there's a number of clinical trials and research just in general that's done typically on a face-to-face basis. That obviously can't happen right now. And so we've even seen some of our clients in the pharmaceutical and clinical research organization space that have started utilizing telehealth significantly or in a much, much bigger way to obviously continue to run their research programs or their clinical trials. I don't know if anybody is on here that could potentially speak to that, maybe from UW or otherwise, but I'd be very interested. I think there'd be a number of other folks on this call that be interested in the answer to that. Kelly, I don't know if that's something potentially you could speak of. It's not really your space necessarily, but I'm just curious.
No, it's not my space. I don't know what they're doing and how they're doing it. I do know I work with Elena. Elena's down at, well, she's home now, but I'm at the Northwest campus, and we're utilizing Zoom. We're looking at Land School, which is a public school tool that they use to train people. Along with Elena, I'm one of the trainers for the hospital. It's easier to use Zoom with 1 or 2 providers than it is with a room full of nurses or ancillary students. So we had several meetings today looking at that different application to see if we could use it. Right now we're on different domains, network domains, so it makes it a little bit difficult. We're trying to find the best one we can use. One of the things that we're doing now is taking our large training rooms and separating all the students so that they're socially distanced and making sure everything's clean. So we're just continually looking at the different tools. We do have a training tool, Articulate, that we have pre-recorded some trainings, and those are offered online for those who are willing to take them to anybody in the UW system. But those are not for everyone. Not everyone is inclined to just learn through video learning. So we're kind of approaching a brand new world and learning how to navigate in that world, which I find very interesting in this time.
Yeah, we actually just had a question come in I think that you may be able to speak to, but I'm not sure necessarily. But one of the questions that came in for the patient populations that are in more rural areas that potentially maybe don't have the internet connections of those of us that live in a major metropolitan area like a Seattle, et cetera, is there anything potentially different that you're doing to either help teach those patients or help teach those providers so to conduct telehealth visits? I'm just curious.
That's a good question. And I can't answer that.
No, that's
I
okay.
used to work in a rural area, but at this point we have a different population up here.
Yeah, absolutely. Beckett, I'm not sure if that's something potentially you could speak to. Obviously, multi-care's reach extends most of the state, kind of all over the place. I'm just curious if you guys are seeing any of that, or if you're potentially adjusting to more rural-based organizations or populations.
Yeah, I'm unaware that we've had any significant issues.
Okay.
So another question that we've received on the chat is specifically around kind of billing and documentation handling. What is reimbursement looking like? Is it is it sustainable? Is it helping keep the lights on, or is it just thanks but it's not enough? I'm just curious if there's any folks here, either not only at either a health system level, but if there's individual provider groups or practices that are here that can talk about potentially how they're getting reimbursed or under reimbursed, or different ways that the payers might be helping them kind of transition to telehealth during this time. So Dave, I can take a shot at some of that, right? So part of it's obviously interesting when we've looked at the CARES Act and specifically how CMS has responded to it, and what we're looking at is weekly as they continue to release new codes by which they'll accept, at least under Medicare and Medicaid, what they'll be allowed to bill for in the reimbursement rates. What's interesting is Seema Verna, director of CMS, signaled and then the last couple of weeks that that we think that the telehealth reimbursement model, even though they've put kind of a Band-Aid over it, to obviously help with near-term revenues and reimbursements. Overall, it appears that CMS is signaling that they'll most likely keep these reimbursement codes or a variant of reimbursement codes in place for the foreseeable future. As we look at timeline, not only with COVID, but we just look at the reality on the street, telehealth and the delivery of telemedicine is going to continue to, be the same over the next, 6 to 18 months, at least for the foreseeable future.
Yeah, that makes sense as well. I mean, that's what we've seen kind of across the board as well, even working with some of the state organizations that Mike works with. That's one of the things that's been communicated to us as well. Dylan, do you have any other potential questions that were set up or sent through, excuse me?
Yeah, so we do. So another question that we received is just what is the type of telehealth services that are being delivering, and how complex are we seeing those? I think everybody's familiar with the teledoc, or the doc in the box, where you could you meet with an APN and get a list of prescriptions or whatever it is. But I'm curious to what more complex or kind of the level the treatment level that different organizations have been able to deliver telephonically. Any examples from any organizations in the line would be welcomed.
So I'll share this, Beckett Mackey again from Multicare. I think, I think of two basic patient populations are established patients that require some regular follow-up. They've had good experiences and actually finding a lot of the issues that folks used to have to actually physically drive in for can be managed via telehealth. So I think that's going to be a significant change. On our urgent care side, again, we've got an established urgent care. It's, I guess, not surprising that there's been a significant shift in the types of visits. So our URI, you choose your chief complaint, and the URI volume has obviously gone up significantly in the COVID era. So that's where most of the volume has been. But the other volume is still there. What I've been fascinated by and pleasantly surprised is that of our really large, 40 times higher volume, we are not seeing a lot of people referred for COVID testing. So we're tracking that. And, one of the criticisms that we got was, well, yeah, telehealth is just going to cut in the urgent care space, charge a fee, and then end up referring patients to the EDs. You can imagine what type of physician had said that to me. So looking at that data, that we've had low single-digit percentages of patients that are presenting with symptoms consistent with COVID that are not, or symptoms that they're concerned about, and like only 3% are actually referred for testing. Now, granted, if we had more testing, maybe that would be a little bit higher, but it's a very effective way to filter out at least, say, 90% of people that would be presenting physically for in-person care, which I think is one of the major goals.
Yeah, totally agree. Anyone else?
Hi, David. One of the things that we've been using telehealth for is for rapid testing. We do have the drive-through sites for UW. And if there's any patients that are calling into their providers, we're doing all virtual visits for COVID type related complaints. And then they will send them to the emergency room or send them on if they need to be seen for escalated type of care. Also, one of the things that we did is we bought the telehealth ICU monitors and placed them in ICU when we were at the, pinnacle of the crisis, and our ICU and our step down was full over at the Northwest site. And with the PPEs being on, having so little PPEs, you think you have enough until you get into that crisis mode. Physicians needed some help in the ICU. We had 1 or 2 in-house physicians at night, but the COVID patients were so intensive with the care that they needed that the other patients, didn't get as much care. So we had the telehealth monitors inside the ICU rooms, and then we onboarded new UW physicians who wanted to come volunteer. And then what we did was there's a 1-to-1 ratio for nurse patient. So that nurse always has their PPEs on, they're in that patient room, but the physician is going to different rooms. So in order to conserve the PPEs, what we did was we had the physicians, they'd go in and take a really good assessment look. But then after that first assessment, they were able to use the telehealth video with the nurse in the room taking care of that patient, so the physician didn't have to take off their PPEs 10 different times and put new ones on 10 different times and just do that every hour throughout the day. So it really helped us monitor those patients hour by hour, minute by minute, and in some cases, and conserve PPEs, which we never considered, but that was something that was brought up and by the physicians themselves. It's amazing what the people down in boots on the ground come up with. They have been the ones to create wonderful policies.
That's awesome. Very cool. Anyone else?
I can share another perspective from a client, but part of the reason, so when we think about using telehealth, there's obviously always the emergent things that we need to take care of. But one of the alternative ways within, organizations and using it is most of our organizations that I've worked with are in some sort of value-based contract. And typically these contracts, specifically when you look at Medicare Advantage or other, other kind of riskier, high risk value arrangements, part of that contract, they're typically set up in two parts. One is obviously, bending the cost curve, but the other part is actually making sure that, quality and quality gates are met. And typically how these quality gates are met are through, somewhat tedious or sometimes arduous documentation and coding efforts that health systems and care managers and case managers have to do. And so what's interesting is, at the health system level, what they're looking at is how do we continue to make sure that we're going to be maximizing and getting our reimbursement from our payers in these value-based contracts. So part of what they've been using telehealth to do is actually close those gaps in care and those gaps in coding and documentation. So typically a health system would set up a 45-minute or an hour consult, comprehensive consult with a patient during their annual exam to do all the recommended documentation and coding, to look at the comorbidities, everything that needs to get closed for the various either HEDIS or value-based metrics. So what we've been seeing is actually a replacement of those, and looking, instead of just doing 15-minute intervals and trying to do that, but doing longer patient consults to close that. And again, I think the reality of it is even though there's an influx of patients that are coming in through either the ED or we're dealing with, real-time kind of PPE shortages, there's also the fact that there's still contracts and reimbursements in place, right? And so these organizations are looking to make sure that they can continue to maximize those, especially as we see that overall utilization, from, across the country have went down. The insurers are sitting on larger coffers of money this year than they have last year because of the overall utilization being down. So that's another way that we're seeing that telehealth is being leveraged, is making sure that they can collect all those value-based payments that are due by closing those gaps in care.
Thanks for sharing. Ernie, you just asked a question.
We do have
Sorry, go ahead. I was just
I was going to read that same question.
Yeah, you just asked a question. Do you want to potentially clarify a little bit what you meant by it?
Yeah, sure. So one possibility for using telehealth is not just one physician or practitioner to one patient, but practitioner to practitioner or practitioner to practitioner is present with the patient. So you can leverage someone who's maybe a high-end specialist, maybe a rheumatologist to a remote area or something like that. Maybe allow a nurse to work at top of license or maybe even beyond top of license, which would be really cool. So I'm just wondering if anybody's been leveraging telehealth in this sort of crisis mode to do things like that.
That's a great question.
Unfortunately, no, but we would love to get there. I think it's more a cultural challenge than anything else to do primary care to specialty care, which is typically the model I'm familiar with. The one other area, though, that I've used previously that I was thinking about when we were talking about the ICU setting earlier is also to save PPE using telehealth, the tele-ICU model to do drug and blood admission double checks that the nurses have to do, especially in remote areas. So providing, instead of having two nurses don and doff a bunch of PPE or just having the one go in and out of the room, actually using the telehealth platform from a nursing cross-check standpoint as well.
That's great.
So another question we've heard, and this is that we have here, and this is actually more aimed at the vendor side. But we're hearing from organizations that they've been having trouble getting a hold of certain types of telehealth equipment, whether it be webcams or telepresence equipment. And then I think even if you go to look on Amazon, right, they're 5x or 8x of the normal cost of what it is. So I'm curious from the vendor community on here, if anybody works in that space with equipment or hardware, what are you guys actually seeing from either your suppliers or your group purchasing organizations or the various vendors? Any technology shortages or any interesting things of how they're deciding to allocate certain technology to various health systems?
This is Artina. I might be able to speak to that a little bit. I currently work at in the technology, I guess you could say, reseller space to a degree. And we are seeing a significant backlog in webcams. It seems like such a simple, item. However, it is one of the most requested and one of our biggest backlogged items that we have right now. All of our, we've got thousands and thousands upon thousands of back orders. A lot of the products are either made, what a lot of our organizations are doing, our OEM partners are doing, is they are allocating and making sure that they prioritize healthcare and the most needed areas for webcams. But I can tell you a lot of their organizations are also undergoing the same kind of stay-at-home orders that we are. So manufacturing is down, so they're not able to keep up. Right, so they're not able to keep up because manufacturing facilities are down, backlog, and the really fast adoption of telehealth is impacting that. Headsets also a little bit, but not as much. Those are a little more readily available. Some organizations have looked at monitors with that are enabled with web cameras as an alternative. We also saw a pretty big backlog of mobile carts. So in other words, not your big wow carts, but a lot of for tablets, your smaller carts that on wheels with poles on wheels. Those are pretty backlogged, and so and challenging to get. Really, it is first come first serve to a degree, right? You get your orders in, and then they allocate from there. It's usually how the organizations are dealing with that today and right now.
Artina, as a follow-up, are organizations going directly either to the vendors or the resellers, or are they trying to lean on their GPOs to do that? Or is it all in the above?
I think everyone is opened up to anything goes at this point. This is what we've seen, right? However, but the GPOs, GA, I don't know that the GPOs will have a lot of the inventory can fill, because they're going to lean on organizations that are in the channel and the OEM partners and distribution.
Yeah.
They are, though, like, for example, GHX, they have a website that lists all of the hard to find. And if they've found inventory in some way, shape, or form, they list that on their website. So it's a resource, right, to find hard to find products. We're also doing that. So a lot of organizations are doing that. They're creating a supply chain network of folks that are going out and trying to procure and find and source off the wall anything that they can get their hands on, and then they're making that available, and we're and posting it in various places. I can tell you that our clients are relying on us to make sure that we're out and gathering that kind of data, but they're probably relying on the 5 other partners that they have as well. So whoever gets it. Does that answer your question?
You know, no, that does. And it's interesting because much of what we hear in the news, right, is that, you know, PPE is either, you know, hard to get a hold of or being intercepted, you know, right at the docks of the boats coming in. And so we're hearing stories about that. You know, from a hardware perspective, Artina, is there, when you mentioned backlog, right, you know, is it number of units or is there a time, right? Is there going to be a 6-month shortage? You know, is it 45 days? What do you think?
They have consistently told us it's anywhere from 2 to, you know, 5 months. Consistently, especially for webcams. And I think this is going to be, though that's the story we're getting in, you know, 2 to 5 months. And it specifically for webcams. The cards probably a little quicker because you've got more people ramping up. Also, your headsets are ramping up. Monitors with webcams, you know, a lot of folks are I think those are secondary because a lot of people want the webcams. Mm-hmm. I can share so much more information about it, but I just don't know what information you want.
Yeah. Thank you. No.
Yeah. I think one thing I'd like to share, though, is during the height of all of this, I think a lot of organizations were reaching out and they didn't care as much. They were like, we want whatever you can get. What's happening now is that is narrowing down, and everyone was looking everywhere, online, anything, trying to get their hands on anything. It's narrowing down, and more folks are now starting to align with, we don't want those. We want this capability. We want it to be like, so they're narrowing down on the models and they're waiting longer. And they don't mind waiting.
Yeah, no. Yeah, that makes sense, right? If you have, you know, 10 different types of equipment, right? You have, you know, 10 different things that need to be audited for security, that need to be set up. That, you know, if you have a support desk, well, you need to tell them, you know, look on the back of your camera and tell me which model or version you're using, right? And so that, you know, I think that the staffing alone to be able to support that kind of thing. Yeah, it makes sense. You know, where possible, you know, uniform, right? You know, if available.
Yep.
Cool. Well, we're coming to the top of the hour, so we're going to wrap up here. We appreciate everybody's time. Obviously, this is our very first encounter at this. We're obviously continuously looking to improve. We're probably going to be doing this every few weeks to at least once a month on various topics. So if you have any potential feedback or if anybody wants to share some potential resources that we can push out to our membership, please email us at wa.info@himsschapter.org. That'll come directly to myself, Dylan, and we can push out information from there. And or, like I said, we're always open to feedback. Obviously, we're here to serve our members. We want to make sure that we get the information in your hands and help collaboration. So again, we appreciate the time today, but enjoy the rest of your afternoon, and hopefully you can get out and enjoy some of this nice weather. So we'll talk to you later, okay?
Thank you.
Thank you. Bye-bye.
Thank you.